Chapter 43, Introduction to Pediatric Emergencies and Growth and Development as it relates to the pediatric population. Some of the most stressful calls that a paramedic may run in his or her life is going to be ones that involve children. It can be anywhere from just minor injuries, minor sickness, to major injuries, major sickness, and possible death. Children differ from adults in their anatomy, physiology, and emotions, and during that time, the children and their caregivers are going to depend on you as the paramedic to be the calm in what will be an overall chaotic situation. Your approach to pediatric patients must be based on age because of the growth and development of each child and how they will respond to different situations. And you're also going to have to accommodate developmental and social issues as well. Children perceive their illnesses or injuries differently from adults. Young children may not be able to report what is bothering them, and fear and pain may hamper assessment. Also, you've got to consider the caregivers or the parents in these situations, because when they see their children sick or injured, they're going to be very stressed and very afraid. You've got to, again, be calm in a chaotic situation. Your approach to pediatric patients is going to have to be specialized based on each of the individual patients that you experience. So going through the stages of development with the pediatrics, you'll start with the neonatal period, which is the first month. So a newborn is from birth to the first month, and then the pediatric patient will then be referred to as a neonate within the first month to 2 months. And then infancy is going to be the first 12 months. When dealing with these patients, you've got to remember that the caregiver that is taking care of this infant is around this child all the time. So they start to learn their cries, their specific cries. They start to learn their specific activities, and they do know when something is wrong. And you've got to respect that caregiver's perception that something is wrong. Just because you may not know it does not mean that there's something wrong, because you're not around that child all the time. Watch for persistent crying, irritability, and lack of eye movement. It may be a symptom of serious problem when you start seeing irritability, crying, lack of eye movement, if they're listless or not really interacting. Nonspecific concerns about behavior, feeding, sleep patterns, or arousability can indicate a serious underlying illness or injury. As the infant is becoming more and more mobile as they progress later in the months, increased mobility can lead to injury because they become very curious. Unfortunately, you've also got to consider possible abuse with behaviors that do not match the developmental stage. So if you look at the chart right here, infant development, birth to 2 months, they're not really going to do a lot. They're going to start to be able to control their gaze, but initially a infant or a neonate, they don't do a whole lot. They just kind of sit there and eat and sleep and poop and pee, which is a good thing. But they start to be able to control their gaze, and they be able to turn their head and start holding their head up because their neck muscles are becoming stronger. Cognitive development for birth to 2 months, they begin crying to communicate needs, and as I mentioned earlier, that caregiver will be able to specify what each cry is. It's the craziest thing I've ever seen. I know that with my wife, with my children, she was very much able to pick up on a wah wah, I'm hungry, or a wah wah, I've pooped and I need to change my diaper. I just hear crying. Crying peaks at 6 weeks. With emotional development, they start to develop trust in their parents, but they really don't want much to do with anyone else. At 2 to 6 months, physical development, they can recognize the caregivers, they start making eye contact, they become more aware of the world around them. They explore their own body. They use expressions of joy, anger, fear, surprise, and they start to seek attention. And then 6 to 12 months, this is where they really start to become more mobile and more prone for injury. They're able to sit without support. They start crawling. They put everything in their mouth. Start seeing teething, which that will lead to irritability. Soft foods are starting to be introduced into their diet, and you start hearing babbling, and they start learning their first words by 12 months. They'll remember objects and their toys. They're curious about what objects do. This is where you start to see separation anxiety and the start of tantrums and self-determination while eating, especially when they get to the later 12 months or so. They really start trying to become independent, and this is where you got to be very careful with this age group. During your assessment, you want to keep the neonate and infant warm. If it's a real young infant within the first 2 months, definitely want to support their head because their neck muscles are not strong enough to hold their head up. Older infants will be calmest in the parent's arms, and you've got to always include the parents into the care and the care plan. Let the parents know what's going on. If the child's quiet, listen to the heart and lungs first, because when you go to start listening, they're going to get really upset. Toddler age. This is my youngest daughter, Lainey Lou, in the picture here. This was when she was, I think, right around 2 years old. You can see on the chart here, table 43-2, the different developmental stages that or milestones that these ages hit. The toddler period includes ages 1 to 2 years. This includes the terrible twos. I believe the terrible twos really isn't true because at least we've never experienced the terrible twos, but the terrible threes and fours are certainly a force to be reckoned with. They're not capable of reasoning, poorly developed sense of cause and effect. Their language development is occurring very rapidly, but they're still struggling to put words together, so you've got to be patient with that. They have the growing ability to crawl, walk, run, and climb. This age, though, painful procedures may make lasting impressions, and so you definitely want to approach this with a very calm and reassuring manner. When we start getting into the toddler age, you want to consider using, or you do want to use, a pediatric assessment triangle. The pediatric assessment triangle is used to measure the child's interactions with the caregiver, vocalizations, and mobility. First thing you want to do is examine on the parent's lap. You don't want to just go immediately to the child. You want to get a good appearance of how they're presenting to you. Get down on the child's level, assess their work of breathing and their circulation or their skin color. Talk to the child. Have the parent assist when possible to deal with stranger anxiety. Use play and distraction when possible. Offering choices helps the child feel a little more in control. Remember, though, in almost all situations with children, answers to yes/no questions are going to most likely be no. Consider saving upsetting or painful steps for last, and be flexible. A full head-to-toe exam may not be possible, and you've got to really determine what your priorities are and where you want to focus your assessment. So this is just an example of different critical illnesses or sicknesses that are associated with the pediatric assessment triangle, where you're going to form your general impression. Stable, you would see all legs of the appearance, circulation, and work of breathing. There's nothing that just stands out. Respiratory distress, you're going to see an increased work of breathing. Respiratory failure will be, their appearance will be affected as well as work of breathing. Shock, circulation initially, or depending on what type of shock it is, followed by work of breathing. Central nervous system or metabolic issues, their appearance is going to be different. And then, of course, cardiopulmonary failure, all three of your legs of the assessment triangle are going to be affected. Preschool. So this is Landon when he was 3. This is ages 3 to 5. They become verbal and active. They can understand directions. generally able to tell you what hurts. It may not be able to give you specific details, but they can certainly tell you areas of their body that doesn't feel good. You definitely want to choose your words carefully. Preschoolers are very literal and concrete thinking. Examples of, like, I'm going to take your blood pressure. Well, they're not going to really understand that you're going to just perform a vital sign assessment, and so they're going to wonder, what are you taking from them? You may want to use words like, I'm going to put this balloon on your arm to give it a little squeeze or something like that. But when you start using concrete terms like take, then they're certainly going to take that very literal. They're curious, they want to cooperate, but they're going to be scared. Respect modesty. Let the child participate or hold equipment that is safe. Offer simple choices in these situations, but be prepared for rejection too. Yes, no questions, you want to avoid those. Avoid procedures on the dominant hand or arm. Tantrums may occur when they feel a lack of control or just when they're breathing. Uh, Set limits on behavior if the child acts out, but you definitely want to have parents involved in this situation. School age child, which is a very big gap because there is a huge difference between a child that's 6 years old and a child that's 12 years old. But early on, this is middle childhood. They're capable of abstract thought. They understand cause and effect, and they become more aware of these things as they become older. Um, School is very important with a focus on popularity and peer pressure. I would say as they get older in this class, but um, 6, 7 year olds, they certainly become more aware of their peers and their friends, and they become very important. But they're not quite as worried about popularity and all that. But once they start getting into 10, 11, 12 year olds, and you also see a difference in girls and boys as well. Understanding of death may increase anxiety. They may have their own ideas about medical care, and they may even associate medical care with things that have negative connotations as well. By the age of 8 years, anatomy and physiology are similar to those of adults, just smaller versions. Breasts develop between 8 and 13 years. Menstrual period begins between ages 9 and 16 years. Testicles increase in size around the age of 10 years, and they may be self-conscious about their body image. As always, you definitely want to respect that child and respect their modesty. Ask the child to describe history leading to why 911 was called. Be sure you include this age group in your assessment and your questioning. Explain steps in simple language. Be sure you answer your questions and you answer honestly, because if they catch you in a lie, they're not going to trust you anymore. Adolescents, this is ages 13 to 18, and this is going to be a very difficult age group to deal with. Teens are struggling with independence as well as social and personal issues. Once secondary sexual characteristics have developed, such as breast or facial axillary hair, they treat an adolescent as an adult. As they're getting older, their vital signs are going to start assimilating more into adult as well. Their physiology is going to assimilate more into that of an adult, but their thought processes are not that as an adult. During an assessment, address and reassure the patient. Alienating the patient may interfere with assessment and treatment. Encourage questions and involvement. Address all concerns and fears. Provide accurate information. Respect privacy. And if possible, address the adolescent without a caregiver present, because there's often going to be sensitive topics that need to be discussed, such as sexuality or drug use, alcohol use, and we need them to be honest with us. Let the patient have as much control as appropriate, but you've got to maintain control while you're trying to assess the patient. So the developmental stages we just discussed include the neonate and infant, toddler age, preschool age, school age, and adolescent. Moving on into the pediatric assessment, again, at each one of these age milestones, the anatomic and physiological differences are going to change. You've got to remember that a pediatric patient, a child, is just that. A child has different anatomic and physiological differences. They're not just small adults, and so you've got to make sure that you are using the appropriate size equipment. You're understanding the differences in the assessment when it comes to anatomical structures and physiology. You've got to be able to base your treatment and adapt your treatment plan based on the pediatric patient size. Anatomic and physiological differences can create difficulties with your assessment if you do not understand them. So, just going quickly through a head to toe assessment. The head. Infants and young children's heads are large relative to the rest of their bodies. That's why we have to adjust by putting padding underneath their shoulders whenever we are doing an airway. An infant's head is 2/3 its adult size. Large surface area means more mass relative to the rest of the body. Oftentimes their heads are going to be the center of gravity, and so they lead with their head in a fall. Take care when positioning the airway, just as we just mentioned, because of proportionally larger occiput. Seriously injured younger than 2 years, place a thin layer of padding under the shoulders or upper torso to obtain neutral position, and if they're seriously ill younger than 2 years, place a folded sheet under the occiput to obtain sniffing position. Large head means more surface area for heat loss, so you want to keep them covered for warmth. Also, remember the fontanelles. Be very careful of the fontanelles when they are in infancy. The posterior fontanelles usually close by the age of 4 months, where the anterior fontanelles close by the age of 2 years. The neck is shorter than the adult relationally, and it is a much smaller airway. It can be difficult to feel the carotid pulse or see the jugular veins. The airway much smaller than an adult airway, and it's more prone to foreign body obstruction. Inflammation with infection or disproportionately large tongue will lead to obstruction as well. Remember that during the first few months of life, infants are obligate nose breathers. Nasal obstruction with mucus can result in significant respiratory distress, so you got to be prepared to suction. The epiglottis is long and floppy, U-shaped, narrow, and extends at a 45-degree angle into the airway. It's difficult to visualize the vocal cords during intubation. That's why the Miller blade or the straight blade is always the best to use, so that it displaces the epiglottis over the airway. The narrowest part of a young child's airway occurs at the level of the cricoid cartilage, below the vocal cords rather than at the vocal cords as in adults. The pediatric patient will have a smaller tidal volume. However, they've got a double metabolic oxygen demand, which means that they're going to breathe faster because they're trying to get more oxygen in. They also have a smaller functional residual capacity, which the result of this is proportionally smaller oxygen reserves. So they'll compensate until they run out very quickly. The functional residual capacity is actually the volume of air in the lungs following exhalation, also referred to as the oxygen reserve. Infants breathe faster than older children, with a breath per minute rate of 30 to 60 being normal for newborns. Whereas when you get into the teens, vital signs start getting closer to the adult range. The higher respiratory rate and oxygen demand raises the risk for effects from inhaled toxins. Proportionally larger amounts of toxic fumes are typically inhaled, which can cause the symptoms to occur sooner. Infants use the diaphragm during inspiration, which in turn may cause them to experience muscle fatigue quicker because they're using up much of their reserve. Any pressure on the abdomen of an infant or young child can block diaphragmatic movement, which could cause respiratory compromise. Infants and children are highly susceptible to hypoxia. You've got to be very careful when you're seeing that the child is in a respiratory issue. You've got to make sure that you're handling the oxygenation aspect and the ventilation aspect of maintaining airway and breathing. As you can see here, pediatric pulse rates are pretty different when it comes to earlier ages, with a high heart rate in the neonate up to the 1 year old. As they start becoming toddlers, their pulse rates start to slow down to where once they get to school age, um, it starts to level off. The cardiovascular system, children have limited but vigorous cardiac reserves. They've got a proportionally larger circulating blood volume compared with adults, which means that they're able to compensate in shock pretty well until they don't, and then they crash. Absolute blood volume is less than approximately 70 mils per kg. Injured children can maintain blood pressure for longer periods than adults, even though they are in shock. Suspect shock when an infant or child presents with tachycardia. Bradycardia usually indicates severe hypoxia, and we need to manage this aggressively. Hypotension in a child is an ominous sign, and it is saying that they're decompensating very quickly, and this is going to be the sign that they're about to experience impending cardiopulmonary arrest. Large right-sided forces are normal in young infants, so you may see different changes on the ECG, especially in the inferior leads if you're doing a 12 lead. During the first year of life, the ECG axis and voltages shift to reflect left ventricular dominance. Cardiac output is rate dependent on infants and young children, and that's why their heart rates are much faster, because their body is depending on a faster heart rate to maintain cardiac output. The pediatric mediastinum is more mobile than adults, which gives them a high risk of injury to mediastinal organs. Neural tissue and vasculature are very fragile in the pediatric patient. The nervous system continually develops throughout childhood, and early on the brain and the spinal cord are not as well protected in children. It takes less force to cause brain and spinal cord injuries. The subarachnoid space is relatively smaller than adults, so this provides a less cushioning effect for the brain, and the head momentum may cause bruising and damage, and this is seen in shaken baby syndrome. Pediatric brain requires nearly twice the amount of cerebral blood flow as an adult, which makes even minor injuries very significant, and the brain continues to develop rapidly after birth. Within the pediatric spinal column, the fulcrum is higher and it descends with age, but the head is heavier relationally with the child, so the support or the fulcrum has to be higher. It's closer to C1 and C2. It develops or descends to the adult level as the child develops around C5 through C6. An infant who sustains blunt head trauma involving acceleration deceleration forces is at high risk for a fatal high cervical spinal injury, and school-age children will likely sustain a lower cervical spinal injury, and they may be paralyzed. Vertebral fractures and spinal cord injuries in young children are uncommon. The spinal ligaments and joint capsules are more lax, and so this allows for increased mobility and cord injury in the absence of identifiable vertebral bony fracture or dislocation. However, with a significant mechanism of injury, you need to always assume cervical spine injury and transport with spinal immobilization in the child. Within the abdominal cavity, the abdominal organs of an infant or child are susceptible to injury for several reasons. The abdominal wall is thin, so the organs are closer to the surface, and compared to the adults, children have proportionally larger solid organs which take up more space in their abdominal cavity, less subcutaneous fat, and less protective abdominal musculature. Abdominal distension in a healthy infant is due to two factors: weak abdominal muscles and larger solid organs. The liver and spleen extend below the rib cage in young children, which makes them less protected, and so this could result in significant blood loss if there is significant injury. Kidneys are also more vulnerable to injury. They're more mobile, and they're less well supported. Less protection due to underdevelopment of the abdominal wall and lack of fat surrounding the organs. The duodenum and the pancreas are likely to be damaged in handlebar injuries and bikes, and the organs become more proportional in size and better protected as the child grows. Pelvic fractures are uncommon. Generally, this is only seen with high energy mechanisms of injury. Risk increases in adolescence when skeleton and mechanisms of injuries become more like those of an adult. Adult height requires bone growth, so while the child is young, they're continually having bone growth. Unique areas of the child's bones are the ossification centers or the growth plates. These are made of cartilage and they're pretty weak and easily fractured. Bones of growing children are weaker than their ligaments and tendons, which makes fractures more common than sprains. Most growth plates will be closed by late adolescence, but you can have growth plate fractures, which can be seen with even low energy mechanisms of injury and may lack the degree of tenderness and swelling and bruising usually associated with a broken bone. The chest and lungs. The chest wall is quite thin, less musculature and subcutaneous fat to protect the ribs and the organs. The ribs are more pliable and flexible than in adults, which can lead to significant intrathoracic injury with minimal external findings. Children have fewer rib fractures and flail chest events, but they may have more severe intrathoracic injuries to the thoracic organs. Children are more vulnerable to pulmonary contusions, cardiac tamponade, and even diaphragmatic rupture. The lungs are prone to pneumothorax from excessive pressures during bag mask ventilations. You definitely want to look for signs of chest injuries with suspected chest trauma. With the integumentary system, infants and children have thinner, more elastic skin, higher body surface area weight ratio, and less subcutaneous or fatty tissue. These factors contribute to increased risk of injury following exposure to temperature extremes, increased risk of hypothermia, which can complicate resuscitative efforts and dehydration, and increased severity of burns. Many burns that would be minor or moderate in adults are severe in children, and this is, remember, because of the body surface area to weight ratio. Limited stores of glycogen and glucose are going to make the child more susceptible to hypoglycemia. Also, the children are highly susceptible to hypothermia due to lower glucose as well. You want to keep them warm. Significant hypovolemia and electrolyte derangements are more common as a result of severe vomiting and diarrhea. You want to keep the child warm during transport, prevent the loss of body heat. And this concludes the first portion of Chapter 43, Pediatric Emergencies. We covered an introduction to pediatric emergencies, growth and development, and the assessment. If you've got any questions, please email me, nickray@suscc.edu.